Consult RX podcast. Cole, what's going on, man? How's the new house treating you?
It's treating me.
The new family.
Yep, got a new house, new baby, family of 4. So, running on fumes the last couple weeks, but doing fine otherwise.
That's awesome, man. Congrats.
Yeah.
Congrats.
Yeah, little boy, healthy baby, healthy mom. So
that's awesome.
That's all you can ask for, I guess.
That is very cool. How has the adjustment been to having 2 all of a sudden?
I mean, not as bad as the adjustment with the first, because with the first, you lose all freedom. It's just like all your regular things that you were going to do, you have to do after the kid is asleep,
Right.
So apart from them having to eat every 2 hours, which is not the most convenient thing, that's not too bad,
Yeah,
But I've also been off of work, so once I go back to work, it might get a little harder, I think.
Yeah, that's true. That may throw a wrench into things.
Yeah, there's that whole
But
thing.
no, man, that's cool. Congrats.
Thanks.
I'll probably be joining you here, in the next maybe week or so, we'll say.
Not too far away. It's coming soon.
Anywhere between right this minute in the middle of the podcast to next week. My wife will go into labor.
Yeah, if we don't, I guess, it's very possible that when they listen to this, it happened. It's just a few days.
I'm sure she's going to be tuned in right afterwards.
Right.
But so tonight, what are we talking about? We're doing GERD, I think it is.
Yeah. I'm glad you know what we're doing. Yes, we're doing gastroesophageal reflux disease, GERD, which we really haven't done a full episode on in forever, if ever, that I could find. It's been touched on in various things like H. pylori and peptic ulcer disease, but hasn't really gotten its own thing that I could find.
Yeah, I think it's probably been a part of some of those other ones, but definitely kind of doing its own thing, is a good idea to kind of get through these meds once again, just for, review's sake, if nothing else. PPIs, I'm sure we're all familiar with them, but so much to talk about, and they're used in so many patients. So I think it'll be a good topic, even if it's not one of our more complex ones.
Yeah, a lot of patients self-treating. I think there's some good take-home points with this one too, and
if we just say so ourselves.
And it's not always GERD. That's the thing. It's not always GERD, even though it seems like everybody thinks it is. You know what I mean?
Listen, if it's heartburn, we just call it GERD and call it a day.
Yeah, slap it on there and call it good.
Get that diagnosis code. But this is also going to be an accredited episode, so thanks to our friends at freece.com for partnering with us. So for those of you who are members of freece.com and have an unlimited membership, make sure that you go to the website after you get done listening. Go to the Learn section, click the podcast, and then you'll just click the episode that you're listening to. This one should be on the top of their list, and then you'll be able to access the post-activity test with the code that we will give you at some point during this episode. If you're not a member of freece.com, definitely make sure you check them out. If you've definitely heard of talk, about them numerous times at this point, but definitely encourage y'all to check out their library of content. They have some really, really great stuff on there. So thanks to them for partnering with us. And with that being said, Cole, where do you want to start, man?
Yeah, we'll start kind of at the beginning, the basics of acid and acid production in the stomach, because that is ultimately the issue with GERD, is an overproduction of acid, more so than just normal reflux that people tend to have, but we'll get into that. So the epithelial lining of the stomach contains parietal cells. The parietal cells contain various receptors: histamine, acetylcholine, and gastrin. So these parietal cells are activated, and that stimulates ATPase pumps or proton pumps to secrete hydrochloric acid, and we get the acid in the stomach. It's typically blocked from traveling up the esophagus by a ring of muscle fibers called the lower esophageal sphincter. And you can almost think of it as kind of like a plumbing situation. The esophagus, the LES, the lower esophageal sphincter in the stomach, the esophagus functions as and this is not me describing it, this is actually described in literature as it being kind of a plumbing system. The esophagus functions as an antegrade pump, the lower esophageal sphincter as a valve, and the stomach as a reservoir. So as you have abnormalities that contribute to GERD, they can stem from any component of that system. So it's important to determine which piece of that is the issue if you can. But poor esophageal motility decreases clearance of acidic material. A dysfunctional sphincter allows reflux of large amounts of gastric juice. And then there's delayed gastric emptying that can increase the volume and pressure in the reservoir until the valve, which is the sphincter, is defeated, and that can lead to symptoms of GERD. So I thought that was a nice little picture of it.
Yeah, that's good stuff. I like how you specified that was not your wording, that was in the literature, because you figured someone was going to be like, you didn't come up with that.
Yeah, it was almost a good analogy if I had come up with it, which I have been doing a lot of plumbing stuff. So interestingly, in my new house, we're on septic, and I've always lived in the city and been on, city plumbing and city water. And we've had all sorts of problems. Basically, when it rains really hard, so like a septic tank, I don't know if you know anything about it, but it's just this large giant tank that all of our junk goes into with a lot of water. And then it gets filtered and seeps out through these drain lines into our yard, just all over the place.
Awesome.
So when it rains really hard and the yard gets really saturated, it saturates the drain lines too much. And so our septic backs up and we can't flush our toilets. So it's been this ongoing issue since we moved in that we, didn't realize we'd have to deal with. So I've gotten more familiar with plumbing than I wanted to be. Let's just say that.
That sounds terrible.
So I like the plumbing analogy.
Yeah. Well, I don't know. I would hate that plumbing analogy if I was dealing with that. But types of GERD, if you will. So we have non-erosive reflux disease, which is the patient is symptomatic, but they don't have actual erosions that are visible on endoscopy. Erosive reflux disease, obviously, is when those erosions are present. Barrett's esophagus is where normal squamous epithelium has actually been changed to columnar epithelium. And the reason why that's concerning is because that histology change has happened. The patient has a 30 to 60 times higher likelihood of developing esophageal adenocarcinoma. And so it's something that we want to control GERD because we know the symptoms can result to that permanent damage and, put the patient at risk for that esophageal cancer.
Right. There are typical symptoms, heartburn being the most common, and that's why there is a distinction between just regular heartburn and having GERD. It's normal for you to have a little bit of reflux. Frequently, if it's going to happen, it's going to happen after meals. But GERD would be where it's exceeding that normal amount of reflux, and then there's downstream effects of that, like inflammation of the esophagus or Barrett's esophagus, like was touched on, and that sort of thing. But also regurgitation, acidic taste in the mouth, weight loss. Less commonly, things like non-cardiac chest pain, even like asthma type reactions and stuff like that. So as far as diagnosing it, a lot of times you're going to see it just diagnosed clinically, especially early on, and if a patient is managing it over the counter, or even they don't describe extremely severe or frequent symptoms, you might see it diagnosed clinically. But it is prudent to do some follow-up testing to make sure that it's what's going on and that there's not any more severe complications like inflammation or Barrett's esophagus. But a lot of times it's based on the duration, the time of day, the frequency, and if a patient has underlying risk factors, which we'll touch on. But if they're going to go further, you may see an endoscopy done. About 50%, an endoscopy reveals that about 50% of patients do not have signs of inflammation, which is good. But you might see esophagitis. You might notice signs of Barrett's esophagus in that instance. They can also do esophageal pH monitoring. So it's like an ambulatory 24-hour pH monitoring to verify that there is increased acidity. And they can also do something called an esophageal manometry. The reason they would do this is because it's really the only way to distinguish GERD from something called achalasia, which is like a rare swallowing disorder that affects the esophagus. And the manometry measures the pressure and the force when you swallow. And so it would identify that somebody has a swallowing disorder and be able to distinguish that from GERD. So if there was a concern for that, that's the only way to distinguish between those two.
Interesting.
Yeah. I have a family member
cool.
with achalasia, so I'm familiar.
Really?
Yeah.
Yeah, that seems like it would be extremely difficult to live with.
Yeah, it is. Yes, it is. Yeah.
All right. So where do you want to go from here? Let's see. Should we talk? And I guess some of the over-the-counter medications and things like that I think can worsen some symptoms. I think that a lot of times patients sort of overlook because like Cole said, this medication. Or these medications in general are usually available over the counter, at least in the smaller strengths, and patients are often self-treating, so they're also going to be taking other things potentially over the counter. So some things to make sure that you're checking patient med lists for, asking them if they're taking. Obviously, over-the-counter NSAIDs, even aspirin, can make reflux symptoms worse. Any type of like fish oil products or things that contain the omega-3 fish oils, iron supplements, nicotine replacement can also kind of flare GERD symptoms in some patients. And then some obviously prescription medications like estrogen-containing products, steroids, tetracyclines even, especially if the patient's not taking it with adequate, water. But lots of things just to kind of keep it on, on your radar as far as, making the symptoms worse. And when we go to actually treat the patient, the goal is to obviously relieve symptoms, but also we want to make sure that we're healing that mucosa that could be potentially damaged, and if there's putting the patient at risk for like peptic ulcer disease type thing, or whatever it may be, we want to make sure that we're healing that that mucosal lining and making sure that the patient's symptoms are controlled long term.
Right. Right. So this is one of those instances where lifestyle and dietary modification definitely important, especially in the early phases. GERD does not have to be forever. Reflux does not have to be forever. Inflammation of the esophagus does not have to be forever. But when it progresses to Barrett's esophagus or something more severe, then it very well may be forever as far as the treatment goes. But we can make lifestyle changes in terms of diet and exercise and what we eat to decrease our risk for GERD and definitely reduce the symptoms along with or before using medication. So avoiding aggravating foods and beverages, if it is alcohol, caffeine, chocolate, citruses, peppermint. I saw one place mention the onion family, and all I could think was I feel bad for that family. I'm sure the onions are very nice people. Reducing fat intake. Avoiding eating 2 to 3 hours before bedtime. I'm not even sure how that would ever be possible for me. I would just wake up in a fit of hunger if I didn't do that. But that's what's recommended. Fluids are okay, but food within 2 to 3 hours before bedtime. Remaining upright after meals. I've seen a suggestion of remaining upright for 3 hours after the meal. So if I did that, I would literally never lay down. Losing weight, obesity is definitely a significant risk factor. So whatever they can do to lose weight, and if they are obese and qualify for weight loss medications, there's a lot of that going around these days, and that can be beneficial in this instance. Nicotine use, reducing or discontinuing that. Elevating the head of the bed. I've seen a recommendation of 8 inches of elevating the head of the bed, and then avoiding tight-fitting clothes, especially around the abdomen. Things that are going to move around and compress the stomach and possibly just increase the pressure on the sphincter that would increase your risk for reflux.
I had a student one time that was talking to a patient about lifestyle changes for GERD and whatnot, and was completely serious in her recommendation, but it was just funny that the way it came out. She's kind of like you can raise the head of the bed slightly. You could put like a book underneath there. She's like, you can go just buy a Tempur-Pedic that does it for you. I was just like, I love that. That's like also like, just so you know, like they also make these super dope beds that do it for you.
Just grab a grab a cheap book off the bookshelf or go buy a $3,000 bed. Either one is reasonable option.
Either way, honestly. Neither one's going to be better.
While you're at it, just drop by Tempur-Pedic and get your sleep number. I mean, you might as well.
Yeah, you might as well. But yeah, I just thought that was hilarious, and I was like, okay, we'll talk about that later.
Just get a hospital bed. I mean, as long as you're going all out, just get a hospital bed, and you get a lot of customizability there.
I imagine that Tempur-Pedic's more comfortable than a hospital bed, but I could be wrong about that. They'll sponsor
Yeah.
the podcast, and then we'll tell people the truth.
As we were in the hospital, Anna's sleeping on the hospital bed, and I have this little couch thingy that I'm having to sleep on, and I'm thinking I'm getting the raw end of that deal. But at the end of the stay, she goes and sits on the couch and is convinced that the couch is more comfortable, and basically says that I'm living in luxury. I'm like, okay, great.
She'll tell her, like, look, grass is always greener. Okay.
The hospital stay is
Even
when the hospital
on that
stay
couch.
is good. I know I did, and even when the hospital stay is good, it's just the worst to have to do that for a couple of
To
days.
have to just
so.
stand there while somebody else pushes out a baby. It's exhausting.
It's horrible. Now, fortunately, it all went very smooth, and it was way faster with the with the second baby and all that. So it was good. It was good for me, at least.
Yeah, that's ideal, honestly.
I'll say that she says that it was smooth. It's not just me. She says that it was smooth. So
That's good.
yeah.
I'm glad she agrees. You're telling me it was nothing.
No,
It was the worst time of my life.
yeah.
All right. So, what do you want to start medication wise?
Yeah. So how about with antacids? Or I'll give a kind of an overview of some of the things, and then maybe we can talk about some of the basic stuff that people would probably start with. But there's antacids, of course, over the counter. There's H2 blockers, histamine receptor antagonists, proton pump inhibitors, which we're all very familiar with, and then prokinetic agents. There's also a newer agent that we touched on previously called a potassium competitive acid blocker. That probably isn't going. You're not really going to see it used here, but it's out there. Initially, the treatment's going to depend on how severe it is, how often it's happening, and that sort of thing. We don't want to start with the maximum therapy, or I'm sorry, starting with maximum therapy may be appropriate in patients who have more severe disease like esophageal erosion. For patients with mild disease, we don't always just want to go straight to PPI. Having them start with an antacid and seeing how that goes, lifestyle modification is very reasonable. But advantages of some, there's some with rapid symptom relief, avoidance of over investigation, and then others, there's disadvantages like potential over treatment, higher drug cost, increased adverse effects. We'll go through all that as we talk through each of these.
Yeah, you're talking about for like as far as starting with max therapy.
Yes.
The advantages of that. Yeah, I gotcha. And so it's kind of starting at the bottom. Antacids. When we think about the different available, over-the-counter options, there's a plethora, and so calcium carbonate Tums is probably, at least in my opinion, the most commonly used one that I see. There's also like Mylanta that's calcium carbonate and has magnesium as well. Milk of magnesia is a magnesium hydroxide formulation. There's also Gaviscon, which is basically milk of magnesia with aluminum in it. Then there's also Alka-Seltzer, which is sodium bicarbonate, aspirin, and citric acid. And of all those options, the calcium carbonate is probably the safest option as well. Mechanistically, these are basically just working to neutralize the gastric acid. So when those electrolytes are released into the acidic environment, you're producing salt and water basically. That's going to raise that intragastric pH and hopefully decrease the activation of pepsinogen and increase that esophageal sphincter pressure. As far as the onset of action, these are very good for someone who's experiencing reflux symptoms and needs pain relief. Now that they have a very, very rapid onset of action. Usually, we're talking minutes, and the downside of that though being the very short duration as well. So patients end up having to use these more frequently, throughout the day if, their symptoms are more severe. And so it's something you just have to keep in mind. These could be, from your more like very mild, very occasional patients. Maybe they go and they're eating something that they know is going to cause some heartburn. Maybe this would be an option for them. But other than that, they're probably not going to be used as a first line option just because they're not going to be all that effective.
Right. You might say for intermittent, therapy less than twice a week or so, or they can be used for breakthrough therapy with PPIs and H2 blockers. When I was in college way back in the day, I say I did. I still have terrible eating habits, but I had really bad eating habits then. Like I would stay up really late, 3 in the morning
Unbelievable.
studying and stuff, and I would just down like a whole bag of Doritos, flaming hot Doritos.
Of
Um,
course.
Drinking diet sodas or regular sodas. And so I would for a while I would wake up and I would just feel like just kind of sick to my stomach. And I imagine it was probably
Now in hindsight.
now in hindsight reflux of some sort. Um, so somehow I figured that out, in my non-medical way that was probably what it was. Instead of going to the doctor, that's what I did. So I
That's
started to
good.
take a Tums before I went to bed, and it took care of the sour stomach. That's the best way I can describe it. And so since then, I've literally taken a Tums like every night since I was in college, which has been 10 years. My family's very concerned about it. I have no concerns, of course, though there are issues that can arise with taking Tums or any of these antacids consistently. With the magnesium-based ones, it can cause loose stools. With the aluminum-based ones, you can have constipation. You could also have hypophosphatemia. With the calcium-based ones, which are the ones I take, constipation, bloating, belching. Can't say that I've never experienced those things. And then also there's some combination products which contain simethicone, and which is, of course, the Gas X or the anti-gas medication. If patients are renally impaired, the aluminum and magnesium products can cause a problem. So they're not recommended with a creatinine clearance less than 30 because they can accumulate with severe renal impairment. So, yeah, a lot of Tums for me.
Yeah, that's good. Well, again, we're not advocating that, but
Not saying that's the right thing to do.
That's Cole's
Just-
personal choice
Just saying that's what
to put too
what
much
I do.
calcium in his body.
Never even mentioned. Actually, I did. I think after my mom was just so concerned that I was taking one Tums every day. I did mention it to my provider, and he was like, "Not worried about
Look, don't try to save it now. It's too late. You've been ousted. No. I don't want to hear how you told it to your provider.
it." At least it's not a PPI every day.
Yeah,
At least
I
it's
mean,
not that.
heck, I'll take 2 PPIs a day and see what happens.
Right.
I'm just kidding. But the other thing to keep in mind with antacids, the Alka-Seltzer that I mentioned, the sodium bicarbonate component of that is going to release more than 500 milligrams of sodium per tablet. So a patient that has underlying cardiovascular issues, cirrhosis, that's definitely not going to be a good option for them. So definitely something to, steer patients away from. And then in general, you have to really limit, obviously, the interaction with other medications that have a limited bioavailability, or some that, when multivalent cations can bind to the drug and limit its absorption, that's something that obviously antacids can be a factor in. So antiretrovirals are always a big one to check for interactions. Certain antibiotics like fluoroquinolones, tetracyclines, all have that multivalent cation interaction. And then certain products, iron, even like ketoconazole, itraconazole, thyroid products, all of those obviously, for different reasons are going to have interactions. So you need to separate it by, a certain amount of time, or, maybe, avoid it altogether in some situations. But just keeping an eye out for the interactions, even though that's an over-the-counter product.
Yeah. Yeah. Guys, that all for antacids? You want to move on to H2s?
Yeah. Let's do that. I don't have nothing else for antacids unless you do.
Nope. Other than I'll be taking one tonight.
You're such a rebel.
I know. So H2 blockers, referenced them before, but that's another option that's over the counter and prescription. Histamine 2 receptor antagonists. There's a few: cimetidine, nizatidine, which I've never really seen, and famotidine. There was another one that had been taken off the market. What in the world was that called? I'm blanking on it.
Ranitidine?
Ranitidine. Yeah, the one that was used the
That was
most.
that was like 2 years ago. How'd you forget that already?
I think that was more than 2 years ago.
Was it? Oh man.
Yeah, we're getting old.
Yeah.
That had to have been
Yeah, it was
3 to
probably like
4,
4 or 5 years ago. Yeah, you're right.
pre-COVID and all that.
Oof. Yeah, you're right. No.
So yeah, famotidine is probably the most common one now. It actually has some, which is branded as Pepcid. It has some combination products. Pepcid Complete also has calcium carbonate and magnesium hydroxide in it. Duexis has famotidine plus ibuprofen, which if you've heard us talk about the NSAIDs before, taking one with a PPI can decrease risk for gastric ulcers and that sort of thing. I guess this is along those same lines, or that was the idea behind this, but famotidine plus ibuprofen. Anyways, they reversibly inhibit H2 receptors on the parietal cells. They decrease gastric acid secretion. They can be used as needed for infrequent or mild heartburn. You'll also see them frequently used daily. So they can be used as a maintenance therapy for mild GERD symptoms. For patients who complete 8 weeks of PPI therapy, they must be able to remain symptom-free on an H2 blocker as far as discontinuation.
Weaning off the PPI.
Weaning off the PPI, yep.
Have you ever seen, I think you said you hadn't seen it, but desantidine, have you ever seen anybody actually on that?
No, I have not.
So I really was hoping that like I could find some like really like weird, it's got, this thing on its chemical structure, which makes it, useful in this random off the wall, disease state or whatever. That's what I was really hoping for. Cause I saw it prescribed on someone's, profile as like, I look at the diagnosis as GERD. I was like, huh. Like
That's it.
I thought they were trying to get, fancy on me, but I even looked it up to see like if there's anything different about it. And I think it's one of those things that was just coming out around the same time that cimetidine was on the market and kind of like one of the market leaders. And so it was like less drug interactions and things like that. But when famotidine hit the market and probably got over the counter status, that probably knocked, the other ones out of the water. But
it did. And I just saw that it was 2020. It looks like around April of 2020 when the Zantac ranitidine recall was. So just right around COVID when that was happening. And I think we've mentioned this before, but I had almost forgotten that, obviously Zantac probably got a pretty bad rap back then, right? But then you can find Zantac on the counter
the
again.
new formula.
Which is just famotidine.
It's a brand new formula, dude.
It's brand new. It's Zantac 360.
You thought the old stuff we made was good? Well, check out this stuff.
They added the 360 on the end, so it's Zantac 360.
I mean,
they did a full turn.
They did a full turnaround and basically
then continued the same
changed
direction
into a different product.
Doing famotidine.
Yeah, we did a full circle and then kept doing the path we were on originally.
Isn't that hilarious?
Yeah, I love that new formula. It's like this awesome graphic. It's just like, man, we gotta start coming up with new drugs.
It'll just drive you crazy, won't it?
It's pretty funny. I gotta respect the hustle, I guess you can call it.
They figured that there's still a brand name that there's still brand power out there, so they're like, let's keep making money on this brand.
Yeah, exactly. But you'd think the brand wouldn't be that great, but who knows? And sorry for all of you guys listening to me hack into the microphone. I apologize. I'm still getting over some respiratory stuff, so my voice sounds terrible tonight. I apologize.
It's good to get the sickness out of the way before the baby's born. I was actively sick in the hospital while the baby was born. Fortunately, he did not contract it, but I was.
That's good.
Yeah.
Well, that's good news. But that sucks you had to be in the hospital like that, too.
I was just worried about getting sick,
Yeah, that's good.
Yeah.
All right, so H2 blockers, some other things to kind of keep in mind. Even though they are over the counter, they're not without adverse effect potentially. And so some of the warnings that are obviously going to be a little bit more rare to run into, but some things that still to kind of be aware of, especially with chronic use. Some confusion can occur in patients that are on H2 blockers, especially patients that are over the age of 50, patients when they're severely ill or having some sort of renal or hepatic impairment. Those patients are going to be more susceptible to developing that confusion and even delirium from an H2 blocker. With chronic use, and typically when we say chronic, we're talking like more than a couple of years, patients on an H2 blocker can have a potential deficiency in vitamin B12 just because lowering the acidity in the stomach just limits how much B12 is getting absorbed from the diet. And famotidine in particular can cause some QT prolongation in the patients that have renal dysfunction. So if you're using too high of a dose and not renal dose adjusting, that could be a potential side effect to be on the lookout for. And then some adverse effects that are a little bit more common, but some things to definitely be aware of: headache, Agitation and vomiting is listed as a side effect in children less than the age of 1. And with cimetidine, especially at high doses, which cimetidine does, I can't remember which strength it is, but there is a formulation over the counter. Cimetidine at high doses can actually affect hormone levels and cause like gynecomastia and impotence and some other problems. So making sure you're warning patients about that. Now, all of these H2 blockers, for the most part, are going to have an onset of action within like 30 to 60 minutes. And duration depends on the patient and how much, how severe their symptoms are. But we're thinking like 4 to upwards of 10 hours. This is another potential option that you can use for, a situation where you're going to have a meal or something like that that definitely is going to induce some heartburn. So, you're going to take this kind of prophylactically and have your meal, but deal with the heartburn and a little bit less severity with this. So you can use them as needed, but there are people who take them on a more chronic basis.
Right. And some things to consider with renal impairment, if the creatinine clearance is less than 50, you may need to decrease the dose. So take a look at that. There are people who take it daily, like Mike said, though it seems to be best used as needed because you can develop tachyphylaxis, so you can have a tolerance to its acid suppressing effects if you're taking it on a scheduled basis. So if a patient reports that they've been taking it and then they needed to increase the dose to 40 milligrams or whatever, famotidine, and then it's over time ends up not working, it could be that they developed a tolerance to it. So either switching or a drug holiday, I would imagine, would be a reasonable thing to try. They can be used in pregnancy. A lot of times you'll start with the antacids. I think the calcium carbonate is safe in pregnancy, though there are some of those antacid formulations that are not as safe. So just be sure to take a look at that if a patient's asking about it. Available over-the-counter and prescription, like we said. You should still write a prescription for an over-the-counter H2 blocker to ensure that the patient gets the correct med and the correct dose. Like we said, it can be confusing, especially with all the different branding that goes on and combination products and Zantac 360. So if you want them to have a specific drug with a specific dose, just write a prescription. They're not expensive, especially famotidine.
Yeah. So some other things to consider as far as drug-drug interactions. So if a patient has any kind of like CNS depressant on board, especially an elderly patient, like in this case, we said 50 and over increases that risk of confusion, delirium. And so if the patient has any kind of like CNS depressants on board that they're taking along with that increased risk of, additive cognitive impairment, delirium, and so forth. Cimetidine in particular is known for its drug-drug interactions, and it's a moderate inhibitor of 2C19 and a weak inhibitor of 3A4 and 1A2. So thinking along the lines of like amiodarone, clopidogrel, phenytoin, warfarin are all going to be potential things that it interacts with. So given the side effect profile and drug-drug interactions, usually you have to dose it multiple times a day. But cimetidine, in my opinion, would be the one to probably stay away from. And pretty much famotidine is the only one I typically would utilize in this class now that ranitidine's gone.
Is this a good time for the password?
Yes.
Nice.
So let's password
That's all we
will
had
be
for histamine blockers, so I figured.
Yeah, so we might as well throw this password in here, and it's going to be GERD24. So GERD 24, all capital letters on the GERD. That's your password. Make sure you go to freece.com's website and take the post-activity test. 10 questions, and you'll get your 1 hour of continuing education credit. There you go.
Nice. So now we'll move on.
Nailed the password. Good job remembering, Cole. One of us has to do it every time.
It's the best part of the podcast. So now we'll move on to the PPIs, the proton pump inhibitors. Always seem to be a hot topic in some way, and they have been for so many years because there's concerns, then they're kind of fine, and then there's concerns, but then the benefits outweigh the risks, and blah, 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 blah. So we'll just kind of lay it out as best we know, and a lot of the concerns are not like definitely you're going to die, even though you hear some people say things like that. I think the biggest takeaway point for me is the duration, the recommended initial duration of them in patients who don't have severe disease. So anyways, there's a host of them. rabeprazole, pantoprazole, omeprazole, lansoprazole, esomeprazole, dexlansoprazole. There is a combination product of omeprazole plus sodium bicarb, which is Zegerid. But they irreversibly bind to the gastric hydrogen potassium ATPase pumps in the parietal cells. And they form disulfide bonds with cysteines. They shut down the proton pump, and they block gastric acid secretion. And ultimately, that's what they're doing, and that makes sense based on what we kind of talked about as far as the pathophysiology of the hydrochloric acid secretion, right?
Yeah, and the other thing to keep in mind too is if these are working properly, they're shutting down that parietal cell, which if you look at the downstream effects of an H2 blocker, that's kind of targeting eventually the parietal cell as well. So a PPI used properly and being, taken the way that we'll talk about here in just a second, taken appropriately to make sure it's getting absorbed and utilized, then you shouldn't necessarily need an H2 blocker. Obviously, there's always exceptions to the rules, but usually it's when a patient's on an H2 blocker, because that PPI is already, if it's working the way it needs to, it should be shutting that off already. That's usually indicating that they're not taking the PPI correctly, or there's some kind of an interaction there. And hopefully you can kind of correct that so that maybe they don't need both medications. Yeah. Sorry, I just wanted to throw that in there since they're the same kind of target cell. I think we sometimes don't think about that.
That's a good point. That's a good point.
Oh, hey, thanks, Cole. Appreciate it.
Yeah, anytime.
As far as the effectiveness, PPIs are definitely the best option we have, especially compared to just the H2 blockers or TUMS. However, like Cole was saying, some potential long-term effects, and the recommended 8-week course is typically utilized for patients that are even working on healing some sort of a GI erosion, GI ulcer, and an 8-week course of a PPI can be enough to heal that mucosal lining and kind of get them on their way. But patients can definitely end up on these very, very long term, in some cases years and years and years and years, and it's one of those things that's just sometimes gets overlooked and refilled and continued on and on. And so I'm not saying that we should keep these on indefinitely or take them off immediately. I think it does need to be patient specific, but also making sure that we are revisiting the need for these medications as we go, because there's so many different options. There's not any perfect study that shows that one is better than the other. Sometimes it really just depends on the individual patients. Some respond better to one agent over the other, but it's something that you kind of sometimes have to go through a couple different options in order to find the one that's working for them.
Yeah, I think that's my biggest takeaway point. Like I said, is that it doesn't mean that they're going to be on these forever, that they should be on these forever. After a solid 8-week course, along with lifestyle therapy, let's at least look at it and talk to the patient about giving it a try. It can be challenging because as they come off it, they might have some rebound reflux and that sort of thing. So you kind of have to wean it. But especially since they're over the counter. So likely patients are already taking this. Many instances I've seen in people that I know where it was recommended to be discontinued, and the patient told the provider that they discontinued it and then just continued it over the counter. So just have set expectations at the beginning and have a conversation with them about it, and see if it's possible to get them off of it. And just because they have inflammation, just because they have erosions, doesn't mean it has to be forever either, because those can heal. Barrett's esophagus, that's different. So as far as the dosing, so many times, especially when patients start self-treat over the counter and then come to you that way, and you say, well, let's try, omeprazole and see what happens. They're going to say like, well, I've already tried that. I was taking like 7 of them or whatever, and it wasn't doing anything.
Classic example.
It's a classic. 7 omeprazole at the same time. Well, if they were doing that, they were probably doing it right before they ate, because this is the most important point, which we've mentioned a million times, and it still somehow does end up being missed. So because everybody in the world listens to us, but the half-life of the medications, generally speaking, is very short for most of them, 1 to 2 hours. So if you take it and then don't eat for a long time, it might be out of your system pretty quick. But it needs to be taken 30 to 60 minutes before a full meal for all of them except for Dexilant. That's the exception. 30 to 60 minutes before a full meal. They need to be absorbed on an empty stomach, and kinetic studies have showed that the absorption is lowered by as much as 50% when they're taken with food at the same time. But not only that, it can take some time for you to see the full effect of them. Only about 66% of the ATPase pumps are active when we eat, and that's if you eat a good meal. PPIs only bind to the activated pumps. And then around 20% of pumps are regenerated every day. So it typically takes around 3 to 4 days to get control of more severe symptoms. So take at least 30 to 60 minutes before you eat on an empty stomach, and then give it a few days to get all those pumps suppressed, or the majority of them, so that you're on a good schedule with that and keeping them suppressed to get the maximum benefit. And if you do that, and the issue is acid, which there are other issues that could be, we talked about the plumbing system. We didn't even talk about hiatal hernias, which are a possible issue as well. Then it really should work with that single dose per day.
Yeah. And you mentioned that about, the taking it with food and whatnot. The other thing I run into all the time is patients that are taking it at bedtime because they think that, they're waking up with heartburn, or
Right.
They have heartburn early in the day. They take it at bedtime, not knowing that it does have a very short half-life.
Or they have sour stomach in the morning like me, and instead of doing a once nightly antacid,
yes,
they
got
do
the
a once nightly PPI.
grandma's sour stomach is my grandma used to. I don't think I've heard that since I was a kid.
80-year-olds and me, they got the sour stomach.
And you get this very sour stomachs. But the like Cole said, it can be really difficult to take a PPI 30 minutes to an hour before a full meal, and timing wise is very difficult for some people to do that. And so Dexilant, not only is it something that you don't really necessarily have to take in relationship to, or timing it specifically to a meal or away from a meal, but it actually has some biochemical or pharmacokinetic studies rather that showed that its bioavailability goes up with a meal. In fact, like up as high as 50% more bioavailable with a meal. So it has some sort of like dual release, like extended release mechanism. And so I guess it has two different peaks that get released at separate times. So they think that has something to do with it. Like it's not the first peak that's catching it. It's when that acid gets there, that second peak is ready to, I guess, activate all those proton pumps as they turn on. That's the thought process. But that's the one that I've had several this is something I've done quite a bit in actual practice. But patients who come in and they really do need a PPI. They have whatever going on, and when they've tried to come off of it, they can't. And they're on omeprazole twice a day, famotidine 40 milligrams twice a day, and they're just not taking it appropriately. Switch them to Dexilant, and sometimes you can even get them to Dexilant once a day from one of the other PPIs twice a day. So it's definitely now that it's generic, it's a lot easier to get access to. So that's definitely one of my go-to options if patient who's been on meds for a while.
I was going to say it is one of the relatively newer ones, but it's generic now. So do you have any issues getting people on it, or did the insurance ever kick back and say then just do omeprazole or something like that?
I maybe have had to do like a couple prior authorizations on it, but it's usually just they've been on omeprazole or whatever in the past anyway, so I can put that in there and then that gets covered. But I haven't really had any issues. There's no cost issue.
There really is not a reason to not do it. You know what I mean?
It's definitely, I've seen it work pretty well in a lot of patients who the others did not. So I've become a fan over the years of Dexilant.
I wonder if it'll ever go over the counter.
I don't know. That's a good question.
I wonder what could be the reason that the other omeprazole and esomeprazole are, but the others aren't.
I guess I don't know if it's because it's something. It has to be something to do with financial reasoning. I mean, as far as like they're still. I'm sure they're still making at least a generic version of their own product or something. I don't know. I can't imagine that if it was financially beneficial, it wouldn't go over the counter because it's not more dangerous than the others.
I mean, call me naive, right? But I would think that if all things being the same, but if this has a more simple dosing schedule,
Yeah, it would be a
It's harder
no-brainer.
for people to mess up without medical counsel. It would be a better
Yeah.
one to have over the counter.
You'd think.
You'd think.
We should write our congressman about it.
Yeah, I do that all the time. I mean, I talk to
Yeah,
him every
yeah.
week, so
I pen him.
I'll just mention it next time. I don't even know if it's a he. It might be a she. I have no idea.
Just pen a letter to him. So he's gonna get right to it.
And generally, I to be fair, I just moved here, so that's why I don't know who my congressperson.
Yeah, yeah, yeah. No,
That'll be my excuse.
Nobody's judging you.
Thanks, appreciate that. It is an election year.
Yes. Adverse effects.
Yeah. So here's what we'll talk about some of the concerns. There's other ones that you'll find. So here's some of the more common things that you'll hear. Headache, nausea, diarrhea. Those are very possible and are reported sometimes. But then there's concerns with the long-term use of PPIs. So clearly they're causing changes to the acidity of your stomach, the pH. So what is that gonna mean? Is that gonna cause a problem? So chronically, it might promote the growth of microorganisms and increase your risk of GI infections like C. diff. That's a possibility. Could possibly increase your risk for pneumonia. There's definitely been some studies to suggest that it can increase risk for osteoporosis and fractures. So why might that be? The acidic environment can affect the absorption of certain minerals like calcium carbonate needs an acidic environment to be absorbed. So if a calcium supplement is needed, use calcium citrate plus a vitamin D supplement. They can cause hypomagnesemia, so the concern there could be QT prolongation. They can also cause vitamin B12 deficiency. Mike referenced that with the H2 blockers. Can happen with PPIs as well.
Yeah.
Back at the height of COVID, there was a cross-sectional survey published in 2020 that suggested possibly there was an increased risk for COVID-19. Wasn't super strong, but probably more of a concern back in those times than these days, I guess.
Yeah. I think the calcium, absorption and bone mineral density, loss or fracture risk. I think that's something that I run into a lot with PPIs, in patients that are, menopausal patients that are already on, bisphosphonates or something like that. One, that thing you mentioned with the calcium citrate, I feel like is never like something that's recommended to patients. And so that's something that's a very, very low hanging fruit. And making sure that calcium citrate's given to them, along with their bisphosphonate, not calcium carbonate, because calcium's obviously not going to get absorbed without that acidic environment. And then, just making sure that something, like that is taken care of. And then the magnesium, other things that can obviously lower magnesium, the diuretics, iron absorption. If the patient's anemic, that can obviously be an issue. The B12, you have to think about patients who are on metformin and some of these other medications that can lower B12, and so it's usually by themselves. This is my anecdotal opinion, but by themselves are usually not problematic as far as these types of long-term effects. In an otherwise healthy patient, at least in my short time following patients, but it's the one times where I have seen it be a problem where it's causing hypomagnesemia or a B12 deficiency. It's when there's these concomitant, issues going on or medications being taken along with it. And so it's just something to always have on your radar. And, PPIs plus these other things going on could equal a problem.
Right. So there are, I mentioned Zegerid, which is omeprazole plus sodium bicarb. It's relatively expensive. Not too much of a reason to use that I can see because of price. It contains about 300 milligrams of sodium as well, so just be cautious there.
Remember when that went up to like $1,100 or some insane thing?
No.
When it was prescription?
Really?
Yeah, it went insane price, like sky high. I have no idea why.
And it's just kind of unnecessary,
Yeah. You could just take a omeprazole that's got delayed release.
Yeah.
Yeah, that is weird.
There's also a drug called Vimovo, which is esomeprazole plus naproxen. I mentioned the NSAID and PPI thing, so that's what it's going for there. Cost issue there, probably not necessarily, just use them separately. There's also an omeprazole plus aspirin, Yosprala, and I can't really think of any reason to use that.
Exactly.
There's also IV formulations of esomeprazole and pantoprazole, so definitely a situation could arise where that was needed. And then all PPIs inhibit CYP2C19. So we know that there's a variety of things that can interact there. Mostly they're weak inhibitors, but omeprazole and esomeprazole are moderate inhibitors. So there's a concern there with clopidogrel. You always see that kind of pop up. So if it does and the patient needs to continue a PPI, maybe consider one of the others, like pantoprazole. There's some data to suggest that that would be a better option. Even though the data is mixed as to how concerning the interaction is in general.
Yeah, I think that wasn't that done from I think that was done from a study that was, because I think they were looking at a drug that was a PPI and clopidogrel combo, or maybe it was omeprazole, and I think the drug never like made it. I think it got shut down and the company shut down. But I think that the omeprazole and PPI, the omeprazole and the clopidogrel interaction, I think was documented from the research that they did publish from that group.
Interesting.
I may be making that up, but I'm pretty sure that's the truth.
Sounds like a good story either way.
It does either way. Yeah. Sorry, didn't mean to interrupt you.
No, I like interesting anecdotes. Other drugs that they can interact with, they might increase the levels of citalopram, voriconazole, warfarin. They might inhibit renal elimination of drugs like methotrexate, and that can increase methotrexate levels. And of course, methotrexate has a number of adverse effects related to its toxicity, so you'd want to use caution there.
Yeah. Antiretrovirals is another big one that it interacts with.
Yeah.
And since a lot of people are being treated for hepatitis C as well, the velpatasvir-based formulation, so like the Epclusa, and then the ladipsavir regimen, so the Harvoni, both of those can decrease or have their systemic absorption be decreased by PPIs. So just kind of when you have a patient who's, if you are working with those type of patients, making sure that that's an interaction that gets addressed before they actually start the medication.
Right. Right.
You haven't talked about tapering off of a PPI yet, have you?
No, I didn't.
Okay. So I think that's the other important thing to keep in mind, because obviously with there being so many long-term potential risks, the safest option, if in a perfect world, is to get patients off of these medications after a reasonable amount of time. So when you're stopping a medication, that's suppressing acid, obviously that's going to be like taking breaking a dam. Your body's trying to overcome that acid suppression, and so if you just stop a PPI abruptly, the patient's going to get extremely severe rebound, symptoms, most likely. It's not always the case. You always run into the patient that's like, nope, not me. I didn't get a single symptom of it when I stopped it. I was like, okay, well, that's good, but most patients will, and so there's a few different strategies for getting a patient off of a PPI. For example's sake, let's say they're on omeprazole 40 milligrams twice a day. If they're on it twice a day, I always talk to them about how they're actually taking it. And if they're taking it completely wrong compared, they're taking it one at bedtime, not eating anything, taking one with breakfast, whatever. I have them try once a day instead of twice a day, but having them do it with the correct administration directions. So, 30 to 60 minutes before a meal, and see how their symptoms do. A lot of times their symptoms improve from where they were even at baseline, because now they're actually taking it appropriately. And then from there, after the patient's symptoms feel like they're under control, then, I would drop it to 20 milligrams and probably keep them there for a couple weeks, if not longer, depending on how how severe their symptoms were at baseline. And then from there, again, depending on the patient, you could go slow and go to 10 milligrams and do that even for a couple weeks if you wanted to, or 20 milligrams every other day. And, again, it's going to be patient specific and, how severe their symptoms were at baseline. But doing a gradual taper and having, a schedule kind of laid out for the patient, I find is, obviously a helpful way to get the patient off of these meds chronically, and not just leaving them to do it on their own.
Yeah, that's a good point.
Hey, thanks. Just want to make sure we get that in there.
No, but as far as the duration of treatment and things of that nature and setting expectations, I think it's probably the most important thing.
Yeah.
So there are a couple other drugs that you probably won't see used. One is metoclopramide or Reglan. So this is a dopamine antagonist. It's a prokinetic agent that can also enhance the response to acetylcholine in the upper GI tract, leading to increases in motility and gastric emptying. It also increases the lower esophageal sphincter tone. It's not really recommended anymore unless a patient specifically has gastroparesis. It has a boxed warning for tardive dyskinesia that can be potentially irreversible, though we have some drugs for that now. But it's not recommended to be used longer than 12 weeks because of that, and you should avoid it in patients who also have Parkinson's disease.
Yeah. Have you run into that where patients are on metoclopramide for just extended periods of time?
I have. I've not seen any tardive dyskinesia because of it, but I've definitely seen that.
No, it's definitely one of those things where you see it and you're like, oh gosh, you've been on this for 6 months, huh?
Yeah.
We got to figure out what else is going on.
Let's not do that.
Right.
The other drug, which we had touched on, I think in our H. pylori episode, that was approved, I want to say in like 2022 or something like that, is vonoprazan. What is its brand name? Something like Voquezna. Vonoprazan.
Yeah, that's it.
And it is a potassium competitive acid blocker, which could be effective for reflux. It has a FDA indication for reflux, but it's primarily used if it's going to be used for H. pylori, but it also has indications for duodenal ulcers, gastric ulcers, that sort of thing. Not likely anything that you will see, but kind of a unique mechanism. See our H. pylori episode for more detail on that.
We'll link it below, maybe.
Yeah, maybe.
Unless we forget.
If we remember, yeah.
Yeah, but that's like click here above my head to see the next episode. Then don't put the box there because we're terrible editors. But anything else for these meds? I guess we're about out of time, aren't we?
Yeah, that's all I had for the meds. I did want to touch on one other thing, which is that there you can perform a surgery basically to improve reflux symptoms, and even more or less kind of cure the symptoms if that's the problem. There's the most commonly used surgery is a fundoplication, a transthoracic or transabdominal fundoplication. You can also place a device to augment the lower esophageal sphincter. That's another surgical option. But it's effectively something that's performed laparoscopically, where you kind of wrap around the sphincter to increase its tone and decrease the diameter of the hiatus. So it's the same procedure that they use to treat or to repair a hiatal hernia. It's the same thing, but it can effectively cure the reflux symptoms. So wouldn't be for everybody, but there are some patients who might be considered for it. Patients who have symptoms that are not completely controlled by PPIs, patients who may desire a one-time treatment. Barrett's esophagus might warrant this treatment. The presence of extraesophageal manifestations, if cost of the medications is an issue for them, along with some other ones. But just wanted to mention that surgery is an option. I might not have even described it right because I literally read the entire surgical description of a transthoracic fundoplication. And talk about medical terminology. If you ever needed to remember your medical terms, it's when you're reading something like that. It was only 2 pages long, and I had so much difficulty understanding what they were trying to describe because all I wanted to know was how do you perform this surgery? Yeah. So if they were like, oh my goodness, this guy needs an emergency transthoracic fundoplication, here's the 2-page guide on how to do it, I would absolutely not be able to do that. So
yeah, I feel like most people probably wouldn't be able to nail that the first time just based on the manual,
right?
But yeah, I hear you. That's definitely that's never good when they start throwing around medical terminology of something that you're never dealing with. So you forget what the term is, and you're like, oh no, I'm a moron.
It was nuts.
But all right, well, I guess we're about out of time. So thank you all for listening. Make sure if you're a member of freece.com, go to the website, put in that post-activity password we gave you earlier, and take your quiz and get your credit. If you're a pharmacist, nurse, you can get 1 hour of credit for this episode. If you're not a member of Free CE, definitely check them out. They got a lot of great content. Thanks to them for continuing to partner with us. And also wanted to say shout out to our sponsor, Pearls. If you have not checked out their either the website or the mobile app, Pearls, PYRLS.com/core consult RX. And you can sign up for free, get some limited access to the app and all the different charts. And he will give you some charts to keep that involve like diabetes, pharmacotherapy, algorithms, and some of that stuff. So definitely thanks to him. If you want to see a more structured style lecture, PowerPoints type, topics, then we will have our Patreon down below as well. The link to our Patreon is patreon.com/coreconsultrx. And basically the lectures on there are the ones that I do for my pharm students, for my PA students, and the slides are available for download. And if you do sign up for a year's membership, which is like $30 and some change, one of the other sponsors of the podcast, High Powered Medicine book, is available yours in the digital copy, the second edition, thanks to Dr. Alex Poppin, the author. You'll get that if you sign up for the years of Patreon lectures and all that. So lots of good content for $30. I feel like you can't beat that. But thank you guys so much for listening. Let us know if there's topics you want to cover, or if you know someone would be a good guest to be on the show. And we appreciate you guys listening and sticking with us. Have a good night.